Hello, good evening, everyone. I'm going to start the webinar. Myself, Dr. Hina Singla, Program Unit of Vision 2020 India, based in New Delhi. On behalf of Vision 2020 India and Dr. Shroff Charity Eye Hospital Network, I welcome you to this webinar on strengthening pediatric and geriatric screening at community level. So let me introduce our resource person. Dr. Shailendra Sabharwal was trained in ophthalmology in RP Center, AIMS, and completed his fellowship from Glasgow in 2001. He was trained in public health at London School of Hygiene and Tropical Medicine, London, where he completed his master's in public health for eye care with distinction. Presently, he is Director Public Health and Projects in Dr. Shroff's Health Charity Eye Hospital Network and is also affiliated part-time with International Centre for Eye Health at London School of Hygiene and Tropical Medicine, London. Thank you once again for your participation. I request Dr. Shailendra Sabharwal to take on. Over to you, sir.
So thank you for the introduction. I'm Dr. Surendra, Dr. Shroff Charity Eye Hospital, and so I'll be talking about strengthening pediatric and geriatric screening. मैं कोशिश करूंगा कि हम हिंदी और इंग्लिश दोनों में हम बात करें और I think there will be enough time for question and answer. Whatever we can manage to answer, I'll be happy to take the questions. तो सबसे पहले तो why do we need to screen? So if we actually look at the scenario in India, even today, cataract is the commonest cause of blindness. Whereas we all know cataract can easily be treated with simple intervention. Sometimes some of the studies are showing that even up to 90% glaucoma, patients may not know that they have glaucoma. We know that there is 5 to 10% different regional sort of studies are showing of uncorrected refractive error in children, and this rate has actually suddenly shot up after COVID. And so basically जो भी ये सारी conditions हैं इसमें हमें दिखता है कि there is a need for screening because अपने आप लोग नहीं आ रहे. But if we look at some of the studies, why people are not coming. So there's been a study from Dr. Srinivas and L.V. Prasad, where they directed in Hyderabad. In what they found in Andhra was that the barriers which are there for people not coming in, they are shifting. So now we have barriers which are getting important, which are a lack of awareness and felt need instead of just cost. We did one RAB study in central UP, and what we found was that almost 50% of diabetics did not know that they have diabetes, and almost 90% of diabetics who knew that they have diabetes had never got their eyes tested. तो मेन चीज ये है कि अवेयरनेस और जो फेल्ट नीड कि मुझे जरूरत नहीं लग रही, ये आज भी एक बहुत बड़ा थोड़ा बैरियर है जो बन के आ रहा है इंडिया में. और कंडीशन जैसे कैटरैक्ट, ग्लोकोमा, अनकरेक्टेड रिफ्रैक्टिव एरर बच्चों में और इवन डायबिटिक और डायबिटिक रेटिनोपैथी में बेसिक अवेयरनेस या बेसिक अवेयरनेस नहीं है कि मुझे वो कंडीशन है या उसको ट्रीटमेंट की जरूरत है या मुझे ट्रीटमेंट की जरूरत है. So just to share one scenario, which is again from central UP area. This is the picture of one of the villages which are within the 5-kilometer radius of one of our rural vision center. Here we found this woman who was actually had shown at a local practitioner and was sitting at home with this condition in one of the eyes. So some of you might be knowing this is a corneal ulcer, and from the picture itself it looks pretty severe. तो हमें मालूम है कि ये सिर्फ 5 किलोमीटर दूर विलेज थी. विजन सेंटर आना मुश्किल नहीं था. ये कंडीशन ऐसी है जो कि कॉर्नियल अल्सर की, जो कि आंख को ब्लाइंड कर सकती है. बट स्टिल हमें ये जो महिला मिली ये गांव के अंदर मिली, राइट. सो देन इफ वी आर डूइंग अ स्क्रीनिंग प्रोग्राम, व्हेन डू यू से द स्क्रीनिंग प्रोग्राम इज गुड? So I would say that one is the coverage. Suppose मुझे मालूम है कि मेरे लोकेशन में इतने लोग हैं, so what percentage of people I can cover during screening? So that is first parameter. But whenever we do screening, we'll find some people, maybe those like labeled or painted blue, black hair, who would have certain condition that we are screening for. So the next important step becomes how many of them actually reach the care. So सिर्फ स्क्रीनिंग के नंबर इंपॉर्टेंट नहीं है, हाँ इंपॉर्टेंट है कि जितने लोग स्क्रीनिंग हमें करनी थी उनको हमने कवरेज किया या नहीं किया, लेकिन स्क्रीनिंग में क्या हम उन लोगों को डिटेक्ट कर पाए जिनको हम डिटेक्ट करने जा रहे थे। दैट विल शो यू कि प्रोग्राम की स्क्रीनिंग अच्छी है, लेकिन अल्टीमेटली जो स्क्रीनिंग का सक्सेस है वो इस पे है कि कितने लोग जिनको नीड थी वो एक्चुअली वहां तक पहुंच पाए जहां इनके ट्रीटमेंट हो सकता है या इनकी कंडीशन मैनेज हो सकती है। So if we talk about geriatric, which is the old age, whatever we have worked in the field, what we find coming as barriers and even from the study is one, obviously, is the lack of awareness. Where awareness can be of two, lack of awareness can be of two types. One is that sometimes at old age, people accept that these changes that are happening in my vision or in my eye are basically age related and nothing can be done about it. Then obviously there is a barrier of transport. How do you reach the place you want to show your eyes at? Sometimes everything is available, but there's nobody with you to take you. So that companion is missing. And like I said earlier, there is a lack of felt need that I'm okay because anyway I'm not working much, so I don't need to get my eyes tested or get my eyes treated. तो अगर ये चारों बैरियर हैं जिसमें कि अवेयरनेस है बीमारी के बारे में, अवेयरनेस कहाँ पे उसका इलाज हो सकता है, ट्रांसपोर्ट उसकी कॉस्ट कौन लेगा, ट्रांसपोर्ट कहाँ से लेना है, कैसे पहुंचेंगे, मेरे साथ कौन जाएगा, और शायद मुझे जरूरत ही नहीं है क्योंकि मैं तो इस एज में हूँ कि ये तो चीजें होनी ही है और वैसे भी मैं बहुत प्रोडक्टिव नहीं हूँ, मुझे फर्क नहीं पड़ता। So that means that any screening program that we are doing, maybe in the rural area especially, should have awareness generation as one of the important part of that program. So it is not only about screening and finding out people who have poor vision, but also generating awareness. So there have been studies which show that at one moment of time, maybe around 20 to 25% people only will need eye care. But we are sure that if it is a long-term thing, then the rest of the 75% in turn will need some time or the other. So awareness generation regarding the conditions, that they are treatable and where they can access treatment. I think that is important. तो अगर हम अवेयरनेस जनरेशन, अगर हम घर तक जा ही रहे हैं किसी के, तो अवेयरनेस जनरेशन एक इम्पॉर्टेंट पार्ट हो जाता है। नॉट ओनली कि हम बताएं कि ये कंडीशन का ट्रीटमेंट हो सकता है, क्या ये कंडीशन है, बट ये भी बताएं कि कहाँ पहुंच के हो सकता है। और ये लॉन्ग टर्म इंटरवेंशन है कि जरूरी नहीं है जिस घर में मैं आज जा रहा हूँ उनमें सबको आज ही आंखों के इलाज की जरूरत है, लेकिन अगर उनको आइडिया होगा कि ये चीजें हैं, ये सिम्टम्स हैं और ये जगह है जहाँ मैं जा सकता हूँ, that helps. So in all our program that we do, we always tend to keep awareness generation as one of the important factors. Then we are discussing about children. So why children are different when you're doing screening for children? In fact, there are multiple reasons. One, obviously, the needs are different. So the eye conditions or the treatment required in children as compared to old age is very different. Then within children category, we will have one category who will not be younger children, who would not be talking much or will not be giving you vision. So how do you actually screen them? After that, once they become the school going age group, we know that school screening is the norm which has been taken as where the screening should happen. And so school screening has its own sort of different model, and it has to be done very differently from how we do community-based screening. Within the school screening, we find absenteeism and enrollment as an issue. In fact, the latest ACER report, the education report, which has come just 2 days back, shows in states like UP, still the absenteeism is up to 35%. So it is a high absent children that we miss out when we do school screening. Children screening and treatment is technically sometimes more challenging than doing that in adults. So it requires different sort of training and different sort of cadres to do that. Then children are always dependent on parents. Like very old people, children are also dependent at each stage, whether the parents bring them in for the next stage or not. And one thing which we do differently in children is after doing everything, we know uncorrected refractive error is one of the commonest condition which comes out. We give them glasses, and most of the programs like Shroff would give them free glasses. But are they wearing those glasses? Because we know there are multiple factors which cause children not to wear their glasses. तो अगर हम बच्चों में देखें तो बच्चों की क्यों हमें डिफरेंटली करना पड़ता है, क्योंकि उनकी जरूरतें डिफरेंट हैं। कई बच्चे हैं जो यंग होंगे, जो अभी विजन नहीं बताएंगे, फिर भी हमें स्क्रीन करने की जरूरत है। ज्यादातर बच्चों की स्क्रीनिंग हम लोग जो करते हैं वो स्कूल्स में होती है, उसके मॉडल अलग हैं। स्कूलों में जब हम जाते हैं तो कई बच्चे एब्सेंट मिलेंगे, उस एरिया के कई बच्चे एनरोल्ड नहीं होंगे, तो वो मिस होते हैं। और टेक्निकली अगर हम देखें बच्चों में चेक करना और एडल्ट में चेक करने में, बच्चों का चेकअप थोड़ा सा टेक्निकली डिफिकल्ट होता है, उसमें कई बार ज्यादा टूल और ज्यादा ट्रेनिंग चाहिए होती है। और बच्चे अगली स्टेज तक पहुंचेंगे या नहीं पहुंचेंगे अगर उनमें कोई चीज डिटेक्ट हुई है, वो डिपेंडेंट होता है पेरेंट्स उनको लाएंगे या नहीं लाएंगे। और सब कुछ करने के बाद जब हम फ्री चश्मे बच्चों को दे भी देते हैं, तो क्या उसके बाद वो चश्मा पहनेंगे? तो दैट इज समथिंग विच इज डिफरेंट फ्रॉम अडल्ट। अगर हम बात कर रहे हैं कि हम प्रोग्राम को इम्प्रूव करना चाह रहे हैं, देन आई थिंक एनी इम्प्रूवमेंट प्लान शुड बेसिकली मेक श्योर दैट वी आर taking care of the local barriers and also improving the efficiency and effectiveness. So when somebody is screening, are we being efficient? Are we being effective in that area? I think that also becomes important when we are actually trying to say whether the program is improving or not. So in our context, I think what we would like to divide the screening process is into three stages: pre-screening preparation, the actual screening process, and what happens after screening. तो अगर हम स्क्रीनिंग को देखें कि किस भागों में हम बांट सकते हैं, तो स्क्रीनिंग से पहले हमें क्या प्रिपेयर करना चाहिए, एक्चुअल स्क्रीनिंग में हम किन चीजों का ध्यान रख सकते हैं जिससे स्क्रीनिंग और इफेक्टिव हो, और स्क्रीनिंग के बाद क्या करना चाहिए। So one thing which I would definitely like to say, Shroff has been, we have been screening a lot in last 4 to 5 years, and the average number of children that we are screening every year is about 1.5 to 2 lakhs, and then adults between 10 to 15 lakhs per year. But everything that we are doing is in our own context, and that is what I am sharing. It is our experience, and I'm sure others could have different experience in different settings. तो जो भी हम यहाँ पे बात कर रहे हैं वो हमारी सेटिंग का है जहाँ पे हम काम कर रहे हैं। So if I talk about pre-screening, what is the preparation which can actually have an impact on the program? सबसे पहले I think we'll have to talk about structured training. Unless we know that those who are going out, they are going to actually represent your organization, which at the end of the day is a clinical organization. So are they trained well when they're going out? Because most of the screeners that you will have would not have technical background. We try to divide the screening training for screening into three parts. One is the introduction, second is the technical part, and third is how do you counsel. So if I talk about introduction, what we try to include and monitor later on is how would a screener who goes to a door and knocks the door, how would they basically introduce themselves first? How do they introduce their own organization from where they're coming? And the third is how do they actually introduce the program in a way that people find value? If you look at the technical part, so we basically should know that what exactly is the screening including. It can be different in different programs. So some of the programs would have a vision with torchlight. Some of the programs will have only vision. Some of the programs can have only torchlight. But what I would with our experience, we would say we mix it up. We try to at least do vision in all above 5 years of age in any screening program that we do. But for that, they have to be trained because again, they're not technical, and we try to include optometrists who train these screeners. And the last part is counseling. When you find a person who's basically having a problem and a need, how do you counsel that person to reach to the next level? So that becomes also important. It is part of the structured training that we do. तो बेसिकली ट्रेनिंग के अगर हम तीन पार्ट बोलें, तो अगर मैं किसी के घर जा रहा हूं तो मैं अपने आप को इंट्रोड्यूस कैसे कर रहा हूँ, ऑर्गेनाइजेशन को कैसे इंट्रोड्यूस कर रहा हूँ, और प्रोग्राम को, और फिर अल्टीमेटली मैं जब मैं कोई मान जाता है स्क्रीनिंग कराने को, तो क्या मैं स्क्रीनिंग कर पा रहा हूँ, तो उसमें टेक्निकल पार्ट है जिसकी ट्रेनिंग ऑप्टोमेट्रिस्ट द्वारा होनी चाहिए। एंड फाइनली कि क्या मैं जिसको मुझे चाहिए कि जो अगला स्टेप पे जाए, सपोज विजन सेंटर हम भेज रहे हैं, तो वो कैसे उससे बात करनी है, तो ये सारा ट्रेनिंग का पार्ट होना चाहिए। बट दी आइडियली द ट्रेनिंग शुड नॉट स्टॉप in the classroom. So what we try to do is that one, the training is obviously in a classroom and they are being trained, but then we try to give them at least half a day exposure within the hospital on testing people on the visual screening, taking vision. But then also once they go to the field, initial days, ideally there should be a supervision. And that supervision should ideally be by those trainers themselves, who are generally optometrists. राइट, सो दिस इज व्हाट वी ट्राई टू डू कि जब आपका ट्रेनिंग हो रहा है, ट्रेनिंग जितने भी दिन का आप रखते हैं मिनिमम, उसके बाद थोड़ा एक्सपोजर उनको आप हॉस्पिटल में दे सकते हैं, बट जब वो एक्चुअल एनवायरनमेंट में जाते हैं स्क्रीनिंग करना, कुछ दिन तक आपको उनका हैंड होल्ड करके, उनका सुपरविजन करके, और शायद उनका रीट्रेनिंग भी करना पड़े। वो तभी हो सकता है अगर जो ट्रेनर खुद हैं वो फील्ड में एक आधा दिन ट्रैवल करते हैं, उनके साथ कुछ घंटे रहते हैं और पूरा प्रोसेस वहां पर देखते हैं। Within the pre-screening sort of period, we should be able to finalize how we will collect data and how data would be managed. Because as the program increases or in volume, data becomes important, and we'll come to that later. So it should be very clear that how our screening program is going to collect data. वो data collect कैसे होगा, और जब data आ जाएगा तो उसको manage कैसे करेंगे, उसको use कैसे करेंगे। Again, from our experience, जब हमने शुरू किया था, we did not have a software, and now we are only doing software and app-based screening. So we can definitely say that beyond the volume, I think it has becomes very difficult to manage data if you do not have a software and a platform. If we come to actual screening part, how do you improve your screening? I think we all of us and all of us realize that we are doing this for community, but it doesn't work if we don't engage community. And there are different stakeholders in the community. There are those who are village pradhans, there are important people of the village. There would also be your own operated patients. So what we are actually promoting is that before we start screening in a village, there should be a stakeholders meeting. If you get time and if you feel that engagement is missing still, you can have that meeting in between, but we definitely also try to have that meeting at the end. तो किसी भी स्क्रीनिंग में, किसी भी गांव में जाने से पहले परमिशन तो आपको लेना ही होगा, जो भी गवर्नमेंट का परमिशन है। लेकिन उसके बाद उस गांव में जाके लोगों के साथ बात करना कि हम स्क्रीनिंग क्यों कर रहे हैं, हमारे प्रोग्राम में क्या उनको बेनिफिट होगा, कैसे करेंगे, उसके बाद पेशेंट का क्या होगा, वो सारा चीजें पहले डिस्कस होनी चाहिए। अगर हम चाहते हैं कि जो स्क्रीनिंग का रिस्पॉन्स है, जो हमने बात किया कवरेज का, coverage would be good if people agree to screening, and there are more chances that they will accept screening if you have engaged them initially. Again, coming back to the screening process, जो screening का ideally there should be very clear-cut SOPs developed for screening. When I say SOPs, it should be very clear who's going to screen, what is the tool that they're going to use to screen, whether vision is being taken, then what are the cutoffs of vision, whether it is one eye, two eye, how do they actually refer the patient, what is the referral pathway, all that should be very clearly written, and it should be part of the training when these screeners are getting trained. We have also realized that without targets, it is difficult to actually motivate people also. So you have to give certain targets of daily screening and monthly screening. But again, from the experience, I can say that the target should not be stiff. It should not be very stiff target, because otherwise it is just numbers that you get and the end result doesn't happen. It is important how these screeners present themselves. Ideally, they should always carry at least an ID. If possible, weather permit, they should be having some sort of attire, either a coat or a cap or something which recognizes them and makes them, and they should be smartly dressed. There is a different, there should be different SOPs for children and adults, because children require more precise vision. They are getting screened in school, so SOPs should be different. and also maybe the referral cutoff. It is also important to define in your program who is going to screen. Uh, some of these school screenings are being done by teachers, some of them are being done by community health workers, some of them are actually being done by vision technicians. So it depends on your context. In our context, I can definitely say we did actually in a study mode. We actually studied the accuracy of teacher screening in our setting, and we found the accuracy very low. So for us, we do not learning from that. We have not engaged in school screening by teachers. And what we have learned is that even a non-technical screener, if the screening is within a range of a referral point, a non-technical screener can be trained well, but that person should be dedicated, and that person can always do the primary screening. सो स्क्रीनिंग के वक्त जो है आप क्लियर कट हमारे प्रोटोकॉल्स होने चाहिए और वो रिटर्न में होने चाहिए जो कि स्क्रीनर्स को पहले मिलने चाहिए, इवन ट्रेनिंग में पता होना चाहिए। आइडियली स्क्रीनर्स का कुछ टारगेट होना चाहिए जो कि रियलिस्टिक हो, इतना स्टिफ ना हो, कितना ज्यादा ना हो कि वो सिर्फ स्क्रीनिंग के नंबर देखें और लोगों से बात करने का उनके पास टाइम ना हो। जब स्क्रीनर फील्ड में जाते हैं तो उनको पास कोई आईडी होना चाहिए, उनका प्रेजेंटेशन अच्छा होना चाहिए ताकि लोग उनको रखे, क्योंकि उनको लोग आपके हॉस्पिटल की, आपके ऑर्गेनाइजेशन की एक्सटेंशन मानेंगे। एंड देर इज अ डिफरेंट के बच्चों में कट ऑफ डिफरेंट हो सकता है। अगर हम बच्चों के विजन उनको ज्यादा चाहिए तो उनका कट ऑफ हाई होना चाहिए कि वो जल्दी रेफरल हो उनका। कौन स्क्रीन कर रहा है वो देखना जरूरी है। अगर आपके कॉन्टेक्स्ट में टीचर स्क्रीनिंग पॉपुलर है तो बहुत अच्छी बात है। हमारे कॉन्टेक्स्ट में हमने देखा टीचर स्क्रीनिंग एक्यूरेट नहीं थी, तो हमने उसको हटा के नॉन टेक्निकल स्क्रीनर्स यूज किए जो कि उनको हम ट्रेन करते हैं और वो रेफर कर देते हैं नेक्स्ट लेवल पे, सिर्फ विजन और टॉर्च लाइट के बेसिस पे। If we look at the who should screen again, what we have realized is a mix of gender is very important. It helps you in coverage because some places women get better access to homes when men are out. Women sometimes are more comfortable getting screened by women screener. Similarly, if you are going to different geography, difficult geographies, difficult to travel, men are more affected. So it is always good to have a mixed gender in the program. And because we are all ultimately a clinical organization, so we should be very clear what tools are we using. People can use Snellen chart, but it becomes a bit cumbersome, fitting that in at distance and all that. I think there are free Android apps like Peak Acuity that we are using. We found it very accurate and useful. It is a validated app, and that is what we are using both for adults and children. So बेसिकली अगर आपके प्रोग्राम में मेन और विमेन दोनों स्क्रीनर हो तो कई जगह जहाँ पे आदमी को अंदर घुसने नहीं दिया जाता, जब विमेन अकेली होती है दिन में आप स्क्रीनिंग करने जाते हो तो विमेन वो स्क्रीनिंग कंप्लीट कर सकते हैं, और कई डिफिकल्ट एरिया है वहां पे मेन जा सकते हैं। सिमिलरली जब जिस कैसे आप स्क्रीन कर रहे हैं वो टूल क्लियर होना चाहिए। नैरन चार्ट भी हो सकता है बट धीरे धीरे करके कई बार वो चार्ट फेड हो जाता है, उसको लगाना मुश्किल होता है। तो ये जो एंड्रॉयड ऐप हैं जो आजकल फ्री है, WHO का एक ऐप है, पीक एक्यूटी वैलिडेटेड ऐप है, तो हम अपने प्रोग्राम में पीक एक्यूटी यूज करते हैं जिसको कि कोई भी स्क्रीनर जल्दी सीख सकता है और बेसिकली घर के अंदर चेक हो सकता है विदाउट कोई बहुत ज्यादा लाइट वगैरह की इसमें प्रॉब्लम नहीं होती, एक्सेप्ट दैट इट शुड नॉट बी इन वेरी ब्राइट सनलाइट। Whatever we do actually post screening is basically to improve the adherence. That means whatever you are referring, whosoever you are referring, are they reaching the next level? And again, I think there are multiple ways you can improve adherence. First is definitely when you're training your screeners, you can train them better for counseling. So some of the places where we've had resources, we have even tried to use our counselors to train the screeners in that part of screening, where they can talk to the people better and how to refer them. What we have also found is that it is easier for people to reach if they know what is going to happen to them. So in our own setting, we found that the people who are being referred for suspected cataract tend to reach more because the screener is very easily able to share with them how and where they're going to go next, and it becomes easier. Whereas whenever the referral is not for cataract, it is difficult to explain and the less people come. So better counseling, Your screener should know what is going to happen to the patient at the next step. In community engagement is important, and some of the places what we are doing is after the screening we are and trying to re-counsel patients. We actually go back to community. We have a meeting. We share with them what we have done in the screening, and also tell them there are few people who have this severe vision loss, but they are not ready to come. In some of the programs, we are also using Ashas and Anganwadis and training them, and not using them for primary screening, but involving them if possible to make sure that the people who are not coming in after screening and after being detected can be counseled by them. And for children screening, we sometimes even use Anganwadi camps because there they can be counseled there and then by the Anganwadi worker. And we also get under 5 children there. What also we have realized is that if you give dedicated time or a full day in a week to the screener for following up on patients who have not come, that makes a lot of difference. And especially in the children program, they can go back and talk to the parents. They can go back to the school and talk to the teachers. Similarly, in a community program, if they are say in the same village, they can actually go back to the household on that day or that time of the day where they will not they'll be having time for that and they can talk to the people why they have not come up. तो आपके पूरे स्क्रीनिंग प्रोग्राम का जो सक्सेस है वो तब है जब पेशेंट आपके नेक्स्ट लेवल तक पहुंचेगा। और उसमें हमने देखा है कि आशा आंगनवाड़ी को इन्वॉल्व करके जब उनको हम लिस्ट देते हैं कि ये लोग नहीं आए तो कई बार वो उसमें इन्वॉल्व होते हैं। आपके काउंसलिंग की बेटर ट्रेनिंग स्क्रीनर को देके जिसमें कि कोई काउंसलर आपको उनको ट्रेनिंग दे, उनको बताए कि उनका पूरा जब पर्सन को रेफर करते हैं उनको बहुत क्लियर कट होना चाहिए कि उसके अगले स्टेप्स क्या होंगे, तभी पेशेंट आएंगे। और उनको डेडिकेटेड अगर हम टाइम देते हैं दिन का जिसमें वो सिर्फ पेशेंट को फॉलो अप कर सकते हैं, उससे कई बार रिपोर्टिंग जो है वो बेटर हो जाती है। One more obvious thing is that whenever you are referring a person, that referral point should be within reach. So what we are doing at Shroff is that all our screening programs are actually the referral point becomes a vision center. In fact, none of our screening program has hospital as a referral point. So most of the screening would happen between 5 to 7 kilometers, and it has become a bit more convenient for patient to come. Second thing is that when you are referring a patient and the patient is coming to the next step, let's say to the vision center, are these patients getting some sort of differential treatment or do they have to go through the whole process? That makes a difference. So sometimes what we do is that first referral of a door-to-door patient, we make it free. We also try to make sure that when these patients are referred to the hospital, there's a separate counter for them who are coming from the vision centers. So the whole chain is maintained. तो अगर आप पेशेंट को बहुत दूर भेजेंगे, पेशेंट नहीं आएगा, तो रेफरल पॉइंट पास में होना चाहिए। विजन सेंटर्स कैन बी द रेफरल पॉइंट। आपके हॉस्पिटल भी हो सकते हैं अगर वो पास में, लेकिन जब पेशेंट वहां पहुंचता है तो उसको क्या लोग रिकग्नाइज कर रहे हैं कि ये स्क्रीनिंग प्रोग्राम से है, उसके पास कोई कार्ड है या कोई नंबर है, और उसके बाद उसको क्या वहां पे सहूलियत दी जा रही है हॉस्पिटल में या विजन सेंटर में, जो उसको लगे कि मेरे को फिर नॉर्मल पूरी लाइन में नहीं लगा दी। So that gives a good feedback to the community that once we reach, we are taken care of. It is also very important in some of the program where you see lower reporting that there are basically local barriers are known and we work on them. So I can share one recent research that we did. And what we found was surprisingly, patients were not one big group of people who were not coming in. They were not saying that we need free transport. What they were saying was that we need organized transport. That means we are ready to pay for that transport, which was anyway not that expensive in the rural area, but somebody should arrange that so that we can all go together because they might not be having the companion or the confidence to go alone. And the second thing that sometimes that we learned was some of them just said that the time spent on counseling was so low that I did not know that where exactly I have to go, and if I miss my date, then can I go back again? Would there be somebody? So things like that came up. तो अगर हमें मालूम है कि लोकल कॉन्टेक्स्ट में तो कभी कभी बीच में जाके थोड़ा बहुत सर्वे करना चाहिए जो पेशेंट नहीं आ रहे हैं, और हर एक जगह पे डिफरेंट कोई नीड निकलेगी, जैसे हमारे यहाँ पे कुछ बड़े ग्रुप ने ये कहा कि मुझे फ्री ट्रांसपोर्ट नहीं चाहिए, मुझे ऑर्गेनाइज ट्रांसपोर्ट चाहिए, कि आप ऑर्गेनाइज कर दीजिए कि कोई ई रिक्शा जा रही है तो मैं भी साथ में बैठ जाऊंगा, मैं पे कर दूंगा, लेकिन हमको साथ में जाने को मिलना चाहिए। Children again are a different sort of set of population where the barriers are different. And what we have realized is that more you can engage with teachers, it helps. We are doing a program in one of the district in UP where we have realized wherever the teachers get engaged, the reporting of children after screening is much better. So we try to engage them as much as possible. Sometimes the parents don't come to the school much in government school scenario in UP. So what we have tried to do is involve them during the parent-teacher meetings and tell them about this is happening in your school. And if your child gets such and such slip, then you need to travel and where you need to travel. What we have also found out during COVID, we started this door-to-door screening in urban slums for children when the schools are closed. And we found that since when we go to these households, you tend to engage with the parents more or the guardian. So they understand that their child is not able to read in front of them. And then we found the compliance much better. Yes, they were very close to, they were within 5 kilometers or 7 kilometers of the vision center, but they also better. I think the parents' engagement was better, and this is what we found in our program. But in a children program, like I said earlier, it should not end with child reporting once at the vision. If you want to make an effective children program, you must make sure that there is some provision of time and maybe some resources to go back after 3 to 6 months and see how many of the children are actually wearing glasses. And then what we have tried to do with the help of the software that we have at Vision Center, that once the child reports and they have been given glasses, we also try to do the annual follow-up, which, as we know, the power of the glasses can change in the children every year. So at least once a year they should be followed up. So we started calling them. तो अगर हम बच्चों में कर रहे हैं तो हम टीचर्स को जितना एंगेज करेंगे, एटलीस्ट स्क्रीनिंग में नहीं, लेकिन हमें बता के कि इन बच्चों को हमने बोला था ये अभी तक नहीं आया, आप इनके पेरेंट्स से बात करिए। पेरेंट्स को कैसे एंगेज कर सकते हैं, चाहे वो नॉर्मल फोन से करें या कभी कभार स्कूलों में जो पेरेंट टीचर मीटिंग होती है अगर वो वहां आते हैं तो वहां पे इनको एंगेज किया जाए, बच्चों को लेने आते हैं छोड़ने आते हैं वहां एंगेज किया जाए। हमने ये देखा कि डोर टू डोर स्क्रीनिंग अब हम अर्बन स्लम में करते हैं बच्चों के लिए जहाँ पे स्कूल्स कम है या एनरोलमेंट कम है, तो वहां पर एंगेजमेंट अच्छी है क्योंकि आपके घर पे जब आप जाते हैं तो मदर या कोई ग्रैंड पेरेंट होता है वहां पे जिसको पता चल जाता है कि मेरे बच्चे को कम दिख रहा है, तो वो लाने में उनको ज्यादा वो कन्विंस करना आसान होता है। किसी भी बच्चों के प्रोग्राम में हमें कम से कम 6 महीने में जाके जरूर देखना चाहिए एक दफा कि कितने बच्चे चश्मे पहन रहे हैं, और उससे आपको मालूम पड़ेगा कि जो आपकी ग्लासेस की एक्सेप्टेंस कैसी है, काउंसलिंग कैसी है, ग्लासेस की क्वालिटी कैसी है। और कोशिश करके अगर हम कर सकते हैं किसी भी तरह से जिन बच्चों को हम एटलीस्ट चश्मा दे रहे हैं उनका साल में एक बार हम चेकअप के लिए अगर बुला सकें तो वो इम्पोर्टेंट है बच्चों की ग्रोथ के साथ। बट व्हेन वी आर डूइंग अ प्रोग्राम, हाउ डू यू गेट टू नो वेदर यू आर डूइंग वेल, एक प्रोग्राम अच्छा चल रहा है या नहीं? I think that is what I mentioned earlier, that is sometimes something which the software or the apps can help you. So what we should definitely, 3 or 4 parameters we should definitely monitor is how many obviously were screened, but then how many actually were referred, how many were found with some outcome positive, mean that how many were found with certain conditions in the eye. Out of those, how many actually attended the next station, whether it was vision center or a hospital, how many actually attended? This is important to follow, to monitor, because this is something which has to improve and this is a continuous process. And then of those who came, how many actually required the treatment? So suppose in this dashboard, I can see that 225,000 people were screened, about 13% were referred. Out of that, 46% came. And those who came, 90% required treatment, they were actually having that condition for which they were referred. So that you can monitor the numbers and the quality. तो जब तक हमें ये नहीं मालूम कि कितनों को स्क्रीनिंग किया, उनमें से कितनों को रेफर किया और रेफरल में से कितने पहुंचे, और जो पहुंचे उनमें से कितनों को एक्चुअली जरूरत थी, तब तक हमारे बहुत मुश्किल है ये मॉनिटर करना कि प्रोग्राम अच्छा चल रहा है या नहीं चल रहा, उसकी नंबर कैसे हैं, क्वालिटी कैसे है। अगर आपका प्रोग्राम बड़ा है, देन you will also have to somehow monitor each and every screener. So the dashboard should be able to tell you, or the software should be able to tell you how many screening are happening per screener, and what is the sort of percentage of reporting, the percentage of people connected to care out of those for each screener. So you might find surprises where some of the screeners can be doing high level screening, a number of screening, but the number of people coming after their referral are low. Whereas somebody doing moderate number of screenings, they might be sending in more patients into the vision center. So I think this can only be known by screening. तो हमें मालूम होना चाहिए एक एक स्क्रीनर का परफॉर्मेंस क्या है, और क्या वो नंबर जितने उनसे एक्सपेक्टेड है वो कर रहे हैं, और अगर नंबर्स कर रहे हैं तो जिनको वो रेफर कर रहे हैं क्या वो पहुंच रहे हैं नहीं पहुंच रहे। Then there can be multiple stations in the screening. Suppose I'm screening at community, then referring to a vision center, then referring to a hospital. So if there are dropouts, at what stage the people are dropping out? The software should be able to tell you where the dropouts are, कि कहाँ से patient, क्या community से ज़्यादा vision center नहीं आ रहे, या vision center तो आ रहे हैं लेकिन vision center से hospital नहीं आ रहे। आपके पास screener, आपके software को पता होना चाहिए, easily दिखना चाहिए। Next thing is, how do you intervene? Suppose you get to know who 50% of people are not coming. Then how do you intervene? So you need to have certain sort of details with you. So like I said earlier, you should know which station they are dropping out from, whether they're dropping out from community to vision center, or vision center to hospital, or some other station. Where they're not coming from, can it be a village? It can be an area where they're definitely not coming from. Is there one screener who's more effective than the other? And some screeners are screening in a way that they're not coming. So software should be able to tell you that. Whether it is a particular age or gender which is not able to come in. And what is the reason for referral? So if we look at any sort of population, there will be people who are having a distance vision problem. There'll be a problem, people having near vision issues, and there'll be people having eye issues, but not vision issues. तो हु इज नॉट कमिंग, तो अगर आपको मालूम है कि कौन नहीं आ रहा तो शायद इंटरवेंशन कर सकते हैं। क्या वो किसी एरिया से नहीं आ रहे, या किसी विलेज से नहीं आ रहे, क्या पर्टिकुलर एज के लोग नहीं आ रहे, या मेल और फीमेल में कोई फर्क है, क्या जिनको विजन के लिए हम रेफर कर रहे हैं वो नहीं आ रहे हैं, जिनको टॉर्च लाइट पे कोई हमें और कंडीशन दिख रही है जैसे रेड आई दिख रही है या लिड स्वेलिंग दिख रही है वो नहीं आ रहे। अगर हमें आइडिया होगा उन कैटेगरीज का तो हम इंटरवेंशन आराम से कर सकते हैं। देन फाइनली, कैन योर सॉफ्टवेयर शो इज देयर अ पॉजिटिव ट्रेंड, इज द रिपोर्टिंग इंक्रीजिंग, is it doubling, is it tripling, or is it getting better? We talked about why screen earlier from the public health perspective, but we also did a study where we found that actually the screening also helps compared to a normal community activity. It does help in bringing in more people into the vision centers and also more people with the need. So per sort of referral reporting, you have more people reporting with a problem than just coming in for the minor issue. So it will also help in vision center sustainability. So if I just see what happened then to the patient, so we could counsel this patient actually to come to the vision center. From the vision center, after teleophthalmology, it was basically consultation. The patient was sent to the hospital and finally got a transplant done, and was at least the eye was saved. So before I end, I would like to thank all the organizations. Most of our screening in adults is supported by Standard Chartered Bank, but we have a lot of other partners who support us in technology or in screening itself. And so we are thankful to them to support us and to be able to do all these screening every year. And like it was said by Mother Teresa, that we should not only look at numbers. We should not look कि हमने कितना किया है, but कितना उसमें हमने अपना मन लगा के काम किया. That is important. So again, thank you for listening, and I'll be happy to have questions.
Okay. Thank you, sir, for the wonderful session. Here are the few questions. Question one is, if children have large number, we should dilate in the same place or call the hospital.
I think again, it will depend on the policy of the hospital, but I would say that we don't dilate outside the hospital setting. Uh, we one need to take consent from the parent before dilating. So you must have parents with you or guardian with you. And second, clinically, it is safer if it is in the presence of a technical person, so either in a vision center or in a hospital, depending on the policy, not in the community.
Okay, thank you, sir. Tell the name of visual acuity app used at home on mobile.
We are using for capturing vision, we are using the peak acuity. And for managing data, we are either using Peak platform or the Shroff's platform that we developed with the support from Seva. So we're using two platforms, and we're using the app is free, so you can use the app for capturing vision with any sort of software that you want.
Okay, if children have large glasses number, so we should. That's the same question. Okay.
Yeah, that's it.
Uh, um, Dashboard for monitoring the program is very useful. Can other technologies like AI improve eye screening initiatives and referral?
Really sort of interesting question and very important question because there are a lot of organizations now. I'm not saying in children, but in adults, they are working with AI where uh, the training and the dependence on the screener would go down. Where that means screener would still go there, but there are people working on the sort of red reflex testing or the imaging, where the AI will guide you to the diagnosis whether the person needs referral or doesn't need referral. So they're working on detecting things like cataract and corneal condition while screening. So it will definitely come in, I'm sure, very soon.
Is there any norms in ophthalmology or vision care where who are eligible to screen and conduct eye screening?
Think so because screening is not a technical thing. I think as long as you can train, what government says is that no non-technical person should treat. I think that is important. We should make sure that when we are going out and screening, only technical people are actually treating, whether it is glasses or whether it is medicine. That we have to be careful about. But I don't think that as such screening itself has any sort of norms right now.
Okay.
And that is why I think, sorry, that is why it becomes more important that you have very strict training protocols that you follow.
Okay. So, what would be the minimum battery of test you would recommend in pediatric screening?
Again, like I said, I can tell you from my sort of our contact, but there can be others who have different opinion. We, at least when we are screening, we do a very simple sort of a thing. Like one is the vision, which must be tested for all children possible. There should be a basic torchlight examination to detect basic eye conditions or misalignment, squid, like that. If possible, we are also using under 5 children where we're not able to take vision. We are trying to use arc light, which is a very simple sort of a tool, a simple form of ophthalmoscope, which can actually detect a change in the reflex and also detect if there's any obvious alignment issue. Beyond that, actually, it depends on how what the next step is. When you're an optometrist, it becomes a different thing altogether. Then you obviously have to do a good refraction and doing whatever else you can do there. When we ask the child to come to the vision center, it's a full examination on a slit lamp with the, if required, full refraction. And then even a fundus examination by an pediatric ophthalmologist if required, if there's high myopia or so there's no obvious cause of vision loss. So I think that is not part of community-based screening, but that can be defined by the organization.
Okay. Is there any standardized protocol available for children's eye screening?
Yes, there are multiple protocols available. One is also from Vision 2020. There's a protocol from London School of Hygiene and Tropical Medicine. So there are multiple protocols. After this webinar, I can share the link with you and maybe you can share that further. There are national guidelines also for screening, especially for school screening.
Okay. Can the CHP's community health promoters play a role in screening? Uh, this is the question.
So I am not so sure what exactly is a community health promoter, but I can tell you this much that if they are something, they can be sort of two interpretation. One is if they are someone like what we have as government health workers, they can definitely play a role. I think the only issue is sometimes like in our context, these government health workers have multiple other responsibilities. So they may not have time to do screening, but we can definitely, they are closer to the community. We can definitely involve them when we are screening. One, to get people to accept screening, that once they walk with you for some time, people know that it is a recognized program. Second, if somebody is not coming in after being referred, and these community health promoters are closer to community, they can counsel maybe them better and gives them sort of confidence that wherever they're being referred is a good quality place and they'll be taken care of. So I think they can definitely be used in that context.
Okay. How can we know the most of the people can suffer from cataract and how can we identify?
Yeah, I'm sure the torchlight examination you can capture the advanced cataract, but personally speaking, we have never done a cataract only screening. So what we promote is a more comprehensive. When you're going home, you should not miss other condition. And we generally keep the vision as a cutoff. We are not right now putting too much of pressure on the screeners to diagnose cataract at the household. They can suspect it. They can tell the people that if you have cataract, this will happen. But in our setting, we keep vision as the cutoff for referral. So anybody who, even if there's a cataract and there's a very mild cataract and they don't refer, that is fine. Because anyway, you're not going to do much with a very early cataract with good vision. So for us, I think I would still stress that every screening program should have vision incorporated, vision artistic. And the referral, if on basis of vision, can be more comprehensive. Eh, Unless you see a very mature cataract, which screeners are definitely trained to do pickup, because that becomes something like a semi-emergency and counseling has to be a bit more sort of forceful. But otherwise, I think vision itself is a good referral criteria.
Okay. What is the prevalence of refractive errors in children and what percentage of them require surgical treatment?
Again, the percentage of refractive error uncorrected varies from place to place. In India, what we have found in studies that it can be the average would be between 10 to 15% in schools when we go. Uh, in some of the Southeast Asian countries, it is up to 50 to 70%. So it depends where you are asking for. Uh, and sorry, what was the other one? How the
And
surgical?
yeah, surgical treatment.
Again, I can only share our own experiences. We find the number of children that we screen, we get between 0.1 to 0.2% of children who require some sort of surgical intervention, not more than that.
So thank you all for attending the today's webinar. We appreciate your time, engagement, and thoughtful questions. A special thanks to our speaker for sharing their expertise. We also thank our corporate advisory members for their support. We hope you found the session valuable and look forward to seeing you at the future events. Thanks again and have a great day. Thank you. Thank you all.